There you go. Okay. Good evening, everybody. I am wishing you all a happy new year. I hope that you and your families are staying safe and healthy. It's been rough, hasn't it? I was joking with one of my friends, when this is all over, we should have a mask burning party, because I mean, I don't know about you, but I just, woo, too much. I was sharing with my friends that I've diagnosed 58 people with COVID so far, but the good news is that only one is hospitalized because he's the only one that did not get vaccinated. Everybody else has avoided the hospital and is doing just fine. So before we get started, let me just tell you a little bit of about the Rodham Institute. For those of you that are not familiar with our work, I'm extremely proud of the Institute, the work we've been doing, and our staff. The staff include Ms. Tracy Bass, Ms. Ashanti Carter, who's responsible for these webinars, among other things, in our lovely newsletter, as well as Ms. Christina Williams. We have delivered 560,000 masks and hand sanitizers since COVID began. We've delivered 5,000 meals, and I think we may be going on our 70th webinar. But more importantly than any of that, we are here and standing with the community through good times and bad, and this has been really challenging. I want to put in a plug for the Rodham Institute and blackdoctor.org. We have a State of Black Health that is going to be on MLK Day. Please, it will be live streamed, and as a matter of fact, these guests who are here with us today are going to be making a return appearance. So without further ado, let me introduce my friends. And this is in alphabetical order. Dr. Melissa Clarke is an emergency medicine physician. She is an activist. She has her own radio show. That's why she has such a nice setup. And she is a member of the Black Coalition Against COVID. Dr. Yolandra Hancock is a pediatrician, MPH, has a Master's of Public Health, and she has a site called Ask Dr. Yola. She's also part of the Black Coalition Against COVID. And if you don't know about the Black Coalition Against COVID, the Rodham Institute is also a part of it. It is a national organization which has all 4 of the historically Black medical schools, as well as just about every group that can be represented, from nurses to doctors to labor to teachers to the hip hop community. Who else am I leaving out? Because I don't mean to.
Faith-based.
Faith-based. Thank you so much. So please go, after you visit the Rodham Institute website, we're housed in the GW School of Medicine. Please go visit blackcoalitionagainstcovid.org. There's a lot of good information, and both these lovely young ladies contribute to that all of the time. So thank you, ladies, for joining us this evening. We're very appreciative of you taking time out. There's so much going on, and I know that you've got a lot of places that you're pulled in many, many directions because you are so wonderful and have an active voice in making sure that African Americans, not just in DC, but in the country, get the right information, and people of color in general, but specifically looking at the African American community so that they can make informed decisions. So with that, Dr. Clarke, we're going to start off with you, and we're going to focus on adults with you. Tell us, just start us off and tell us what you're seeing.
Well, let me first say I'm delighted to be here. As I said, when I came on, I wouldn't be anywhere else tonight. I'm just delighted to support the wonderful work that the Rodham Institute is doing. So, you know, what's going on with the Omicron variant? Well, it's incredibly contagious. And as I've been saying, what we got away with during Delta and some of the previous waves, I'm sorry, my headset dropped. Oops, apologies.
That's okay. It's okay. Well, this is a very,
what we got with.
We're at home here. My cat just walked across the table here. So.
Live stream. What we got away in some of our behaviors with the Delta variant and some of the earlier variants is not what we are going to be able to get away with Omicron. And I think we're seeing that with just the catapulting of case counts going up. We were diagnosing around 150 to 160,000 cases a day at the beginning of December. Now it's something like 600 to 800,000 cases a day. One day was even 1 million cases. And I think that's because it's been difficult for people to adjust their behavior. So they had started going back out to bars, started going to restaurants, planned to get together for the holidays and get together with their family. And they proceeded with the plans, unfortunately not realizing how much more contagious the Omicron variant is. The good news is it does seem to be milder, but just because of the sheer numbers of people being infected, we are seeing hospitalizations go up. Thankfully, though, we have not seen an increase in deaths. Now, that still means that we're seeing 1,500 to 2,000 deaths a day. So it's not like that's not a significant, terrible amount of death, but we have not seen, we've seen that stay flat. And we hope to continue to see it stay flat and prayerfully, hopefully go down as the Omicron variant hopefully peaks in the next 2 to 3 weeks.
Thank you, Dr. Clarke. Dr. Hancock, I want to just focus on children because children, and not just their health, of course, which is primary, but their schooling and education has really caused a lot of controversy. We've seen the Chicago teachers go on strike, and frankly, it can be really confusing to know whose side to support because there are so many aspects. So can you enlighten us?
Sure, I'll do a sort of a general overview of what's going on with our little ones when it comes to COVID, and then we'll talk specifically about the school issue. Historically, the conversation has been that children have not been disproportionately impacted by COVID. And for the most part, when compared to adults, that is true, but it's always important to compare children to children. Children aren't just little adults. And when you compare COVID to influenza, more children were hospitalized due to COVID over the span of this pandemic, even if you looked at a 12-month period of time from the beginning of the pandemic till 12 months out, because folks will say, well, you're comparing 2 years of COVID with 1 year of flu. Well, we can compare all of it the same. What we know based on the numbers is that children are more impacted by COVID than influenza when it comes to hospitalizations, infections in terms of total number of cases, and unfortunately, even in terms of deaths. We see children, right now, there was all this concern about, well, children they aren't dying from COVID-19. Children's deaths have exponentially increased since the Delta variant. At one point, children during the Delta variant were making up over 30% of new COVID-19 cases, and we're just second to our seniors in terms of hospitalizations. What we're now seeing is an even higher number of children being infected with the Omicron variant. Their percentage isn't as high as it was with the Delta variant, simply because of the sheer number of grown-ups who have COVID-19. On average, children during the Delta variant, at worst case scenario, we had about 139,000 new cases of COVID-19 among the pediatric population with the Delta variant. We're now well over 300,000 cases per week. The scary thing with the Omicron variant specifically is that we're seeing a higher rate of hospitalizations, a higher rate of ICU admissions because of the Omicron variant and how it specifically causes infection within the body. So prior to the Omicron variant, Delta, Alpha, Beta, OG COVID, all those guys, all the members of the gang caused lower airway infection. So in the lungs, and then COVID could cause anything, as my grandmother would say, inflammation and infection from the rooter to the tutor, from the crown of your head to the soles of your feet. And as Dr. Clarke mentioned, we're not seeing that same wide spectrum of impact from the Omicron variant, but specifically for pediatrics, because the Omicron variant impacts the upper airway, your air tubes known as your bronchi and your bronchioles. Children are more severely impacted because their little air tubes are much smaller than adults. So a significant cold or COVID for us as grownups, because the diameter or the space within our air tube is much bigger, it does not cause us as severe symptoms. But in the same way that influenza disproportionately impacts children, in the same way that parainfluenza, what causes croup, causes more severe infections in children, we're seeing the same thing play out in the pediatric population. And so you're seeing places like New York City, states like Philadelphia, or states like Pennsylvania, specifically Philadelphia, where hospitals are now being overrun by pediatric patients with COVID-19. At Children's Hospital here locally, over 50% of the tests being done for COVID are showing up positive. They have reported that there has been an exponential rise in admissions for children, not just with COVID, because there's a difference. You could have an asthma attack and, oh, by the way, you also have COVID, or you have gastroenteritis and we also tested you and you have COVID. What children are being admitted for is specifically for COVID-19, especially when it comes to respiratory distress, when little ones have significant difficulty breathing. Of the pediatric patients I've diagnosed with COVID-19, I would say at least half of them have either had to go to the emergency department or be admitted because of respiratory distress with no underlying conditions. So these aren't children that had asthma before and it's an asthma flare-up with COVID. This is COVID causing its own issue. So it's important for parents to be able to recognize something specifically called croup. We usually see it with the virus I mentioned, parainfluenza, but you can really get croup with any upper airway bug. It's when little ones have this really barky kind of cough. They may sound like they're wheezing in a similar way that we have seen with something called RSV, or respiratory syncytial virus. It's important for parents to pay attention to the symptoms of their little ones. Pull up their shirts. If they're sucking at their ribs, like when we pretend like we're skinny, that means that they're breathing harder than they should. That is an indication to make sure you reach out to your healthcare professional. If you do not have a healthcare provider, then you make sure you access resources. An emergency department, clearly I don't want everybody running to the ER. You don't have to. If you have a healthcare provider, call them first. If you don't want to wait. You want to make sure that your child is evaluated. And that leads us into the conversation about returning to the school environment in an in-person capacity. You know, one of the things that we have to pay attention to is that when numbers are high and grownups are still going 60,000 deep into football stadiums, they're still packing bars. We're still having restaurant week in New York in 2 weeks. It puts our children at risk, because more often than not, our children aren't getting COVID necessarily from their classmates. It's from the grownups in their space. Now with the Omicron variant being so incredibly infectious, it's just all over the place. And so if we're going to bring our children back to school, it's like this either or, right? But there can be a middle ground. So for some folks, it's like, we need new HVAC systems, we need sanitation Q hour, we need 10 kids per classroom. That's not realistic. But we also don't want to just throw them back in the classroom with no provisions in place. We want to definitely have a layer approach that starts with testing and knowing where every child, administrator, teacher, staff member is as they enter into the school. That means we also have to provide them with the capacity to do it. It's talking through, what does sanitation look like? What does social distancing look like in the real world, so that provisions are in place before our children go back, so that schools don't get shut down because everyone's sick.
So that's a lot of information. And I think what's also making it challenging is that there are other viruses that circulate during this time. And one of the things that I've seen among our adult patients is that they'll go in for a COVID test, but not have a flu test done, or an influenza test done, or let's say strep. And so it's happened that people will call me and say, I have COVID, what should I do? Or I don't have COVID, but I feel sick. And I'll say, go ahead and get the influenza test. They come back and it's positive. And there's actually treatment for influenza. There are medications that one can take. And even if the person has exposed their family, excuse me, there is medicine that can be given to the family to help with that. So,
Okay.
Dr. Clarke, when we hear about, actually there was a question, and maybe Dr. Hancock or Dr. Clarke, that came from the audience about the percentage of Black and Brown children and adults that, what percentage of the deaths and hospitalizations are actually falling into those groups?
So I don't know that we have those statistics yet for Omicron. prior to the pandemic here, prior to Omicron here in DC, what we were seeing was that even though African Americans are 48% of the population in the district, they were accounting for 74% of the deaths. And that was cumulative throughout the pandemic to date. However, some important things happened over the summer, and that was that the gap in vaccination rate nationwide has started to close. And so the disparities between Blacks, Hispanics, and whites in terms of vaccination rates, with whites being more fully vaccinated than those other two populations, Hispanics and Blacks, was closing. And so as a result, what we were seeing in terms of distribution of cases and deaths was that in areas where there was a preponderance of individuals who had voted for Trump, this was actually a study that it was done, it showed that there was a 3 times difference in cases and a 6-time-fold increase in deaths in those between counties that predominantly had gone for Trump versus those that had predominantly gone for Biden. And so it seemed as if, because those vaccination gaps were closing, because behavior seems to be different in terms of masking and social distancing, perhaps in some of the counties that were heavily influenced by the misinformation and disinformation, that you really didn't have to worry about COVID, you really didn't have to get vaccinated. We were seeing some differences there. Now that the booster has come along, and we've seen that with Omicron, with the booster cuts the rate of getting symptoms from Omicron significantly. So it's only the 2 doses of the vaccine, the Pfizer or the Moderna vaccine, are only 10% effective in preventing symptomatic infection. But once you get boosted, it's 75% effective at preventing symptomatic infection. However, they perform great still at keeping people out of the hospital and keeping people alive, as you observed, Dr. Gigi. So we don't yet have the figures broken down by race and ethnicity since the Omicron variant has taken over. That's something that we're going to have to watch closely in the next few weeks to see how this is panning out. The other thing I want to just underscore too is the role of early testing, because as you mentioned, there's treatment for the flu, but it's predicated, it's really important that you get tested for the flu so that you can take it within the first 2 to 3 days of symptoms. Mm-hmm. So the same is true for COVID-19. You want to get tested early. And I don't want people to be fooled that, oh, I didn't lose my sense of taste, I didn't lose my sense of smell, because with Omicron, it doesn't seem to be doing that as much. It seems to be causing those more garden variety symptoms that you associate with a cold or a flu: body aches, fevers, chills, sore throat, ear pain. In the little ones, as Dr. Yolandra mentioned, the croupy cough, but not so much the sense of smell and taste. So make sure that you get tested if you have any of those symptoms. And if you're a high-risk individual, especially if you're not vaccinated, work on seeing if you can get monoclonal antibodies for the Omicron variant. There's only one brand that works, but it does work. So if you're high risk, or if you're unvaccinated, you should, and you're unvaccinated especially, you should see if you're eligible for monoclonal antibodies.
Right. So in terms of pediatrics, here locally in DC, Children's did an excellent job of quantifying race-based demographics in terms of pediatric population. Children's Hospital here in the District of Columbia was the first institution to really look at race-based differences among the pediatric population. And it's a shame that not until just recently did we really start looking at the pediatric population, one, in terms of differentiating race and age, so that we could have a better understanding across the age spectrum within pediatrics who's most impacted. That just happened really over the past couple of months. When Children's presented this data, over 80% of the children in the District of Columbia, and this is pre-Omicron, 80% of the children in the District of Columbia who acquired COVID-19 were Black or brown. 75% of the children who were hospitalized due to COVID-19 were Black or brown, and 80% of the children who lost their lives to COVID here in the DMV were Black or brown. Flash forward a year and some change later, and the newest data shows that over 55% of children who have been hospitalized due to COVID-19 have been either Black or brown. In terms of hospitalization rates, Latino children actually lead African American children in terms of rates of hospitalizations. In terms of deaths, you see similar statistics, close to 60% of children who have now lost their lives to COVID-19, and now it's well over 1,000 children who have lost their lives to COVID-19. The majority of them have also been Black and brown children. But we also have to pay attention to not just hospitalizations and deaths within that population, although as both a pediatrician and as a mommy, it's frightening to me. It's the reason why my daughter is fully vaccinated. And with like any other parent, I looked at the data, I read through, did I have my own concerns just because it's a relatively new vaccine? Absolutely, but I had to, one, I trusted the science. Two, I went to folks who I trusted, Dr. Andrea Anderson, who's an amazing family physician in the District of Columbia, and the first person to teach me how to do a blood draw when I was a medical student. Her son was in the clinical trial. And so I'm like, if Dr. Anderson could trust the science enough to put her son in the clinical trial, I certainly can trust the system and the science enough to get my daughter vaccinated. That's number one. Number two, looking at who was disproportionately impacted by COVID, especially for me as a doctor, knowing I put myself at risk by seeing patients every single day. I did not want my daughter to be caught up in those statistics, right? The other thing I had to think about was how Black and brown children are disproportionately experiencing loss. Even now, I just had two close friends who lost their close family members to COVID within the past week. And so our little ones, and it gets me emotional because I'm like, as grown-ups, we have a hard enough time struggling through loss, right? And there's been so much loss. Every single week, I swear I'm reading an RIP, RIH, something someone is posting about someone who's lost their lives to COVID, even with this less severe version of COVID, right? But imagine Black and brown children who are significantly more likely to have lost a loved one. 140,000 children pre-Omicron, 140,000 children became orphaned during this pandemic because of parental loss, because they were infected with COVID and died. I have colleagues who are losing mothers just as they're giving birth. They are dying within a day of giving birth because they went into the pregnancy unvaccinated, because they weren't able to trust the science enough to get vaccinated. And we know that COVID-19 increases the complications for pregnancy, both for the mother and for the newborn. And so it's all of those things that we really have to think through, especially for Black and brown children. When we think about the fact, and I've heard this statistic actually from Dr. Clarke, when 75% of Black and brown people cannot telework, and we showed up on the front lines, it not only put us at risk as communities of color, it also put every single person next to us, particularly our children, right in the line of fire. They are the collateral damage because we sacrificed to show up to keep the country running. And so we all collectively have to think about that as we progress through. The next time you get ready to go to a 60,000 plus stadium filled with folks to celebrate and watch a football game, you have to think about, how is this going to impact our children? If it doesn't compel you to behave better for yourself, think about the collective impact that it has on our children.
Wow. So there are so many questions, and I think that the answers will probably answer a lot of the subject matter that we were planning to cover, but I want to make sure that the questions are answered. They're great questions. So I'm going to come back to the DCPS one in a second. From Ms. Deidre Mills, my family is vaccinated and we all, with exception of one child, got COVID over the holidays after my husband was exposed at school. How soon can we get our boosters?
So after you have contracted COVID, it's recommended that you wait 90 days before you get the booster, because that way you can benefit from the short-term immunity that you get from having had infection, and then wait until after. I would encourage everyone who is not yet boosted, but has not had COVID yet, to go ahead and get boosted now. Those individuals who are 12 years and older are eligible to get boosters. If you're between 12 and 17, you can get the booster of the Pfizer vaccine 5 months after your 2 doses. If you're 18 and over, you can get either Pfizer or Moderna 5 months after your 2 doses. Or if you got Johnson & Johnson, you can get a second dose of any vaccine, the Johnson & Johnson, the Moderna, or the Pfizer, 2 months after your last J&J dose or your first J&J dose. So now is the time to get boosted if you haven't already, because as I said before, it's 75% effective at preventing symptomatic infection and even more effective at keeping you out of the hospital and alive.
I always get questions in clinic about the timing of the flu vaccine as well as the COVID vaccines, because some people are getting them both at the same time. Mm-hmm. And I'm seeing clinically that people kind of have a hard time when they get them both. Yeah. So I'm suggesting that they actually get them separated by a couple of weeks. In terms of shingles vaccines, which can also cause, sore arm, I tell people to really hold off on them for closer to 4 to 6 weeks because people can get sick. People can not sick. Yeah. When you mount an antibody response and your body is being exposed to these vaccines, you can get tired. So space out the vaccine between the flu and the COVID vaccines by 2 weeks. COVID is the priority because we do have easily accessible treatment for influenza. And I would suggest waiting 4 to 6 weeks for the shingles vaccines. And actually the pneumonia vaccines are also a priority for people 60 and over. I'm sorry, Dr. Hancock, you were going to add something.
That's quite all right. One of the things I would just add a quick caveat in terms of the recommendation. What we know is that your immune response to COVID after you've had an infection lasts up to 90 days. But because we know now based on data that the immune response protection you get from Delta does not necessarily facilitate protection from Omicron, I would sort of take that with a grain of salt, because what you don't want to do is within that 90-day period of time, end up exposing yourself to the risk of acquiring the Omicron variant. I will tell you that my mother had COVID last year and she got her vaccine 2 weeks later because we didn't want to play. And there are, depending on the data source you look at, some folks recommend as early as 2 weeks after recovery so that you don't end up having a flare-up of the inflammation that is always associated with getting a vaccine. The body, as it creates its response, there is some inflammation that's naturally supposed to happen. That's part of the whole process. But in order to make sure that you do not feel as badly as you did when you had COVID, you definitely want to space it out. But just so that folks know, individuals who got COVID like 2 months, 3 months ago, you likely dealt with the Delta variant, and there may not be the protection that you want going into this 90 days. And for children, the only time you really want to pay attention to timing is if you've received a monoclonal antibody treatment. That's going to impact your ability to mount your own natural immune response. And so with that, you definitely want to hold off in terms of giving your COVID-19 vaccine.
And let's not forget there are people who are getting chemo, who are older, who have on steroids for lupus or any number of conditions, so that 3-month time frame may be shortened. So you may want to have a conversation with your clinician about the of that. All of the things that we're talking about, by the way, there are always caveats and exceptions. So this is general information. Please check with your clinician, be it a physician, a nurse practitioner, a physician's assistant, to get the information that is tailored for you as an individual.
Absolutely.
So moving on to some more questions. Let's see. What are your thoughts on reducing the quarantine to 5 days? And this is coming from Ms. Sharon. What do you think?
How long
Yeah.
do we have? I'm kidding.
Yeah. Well, I could say that, I do believe that it was done in good faith from the CDC. And it's based upon the trajectory of the Omicron variant being replicating, so it reproduces itself seemingly quicker than the Delta variant. So the thought is that you are infectious 2 days before you get symptoms and infectious 3 days after. Now, that being said, that's probably an average. My main concern has to do with messaging, because the adjustments were made based upon the Omicron variant. It's unclear what's going to happen after the Omicron variant. And I think once people get used to the idea of 5 days, if we have to go back to the 10 days, it's going to be really difficult to do. Just like when you reverse mask mandates, it's really difficult to get people to go back and abide by mask wearing. So if it were up to me, I would continue to err on the side of caution. But we're in the middle of a nationwide sick out. That's essentially what's happening. Industries across the board, from hospital workers to truck drivers to any service industry you can think of, is operating on a skeleton crew because so many people are sick. And so that was also the other impetus behind, I think, the CDC changing their recommendation, with the understanding that if people no longer had symptoms, they could go to work. The other concern, though, and this is huge, is the lack of symptoms. A lot of people will sort of rationalize it away, like, oh, well, I sneezed once, or I just had a runny nose a couple of times, or my nose is running, but it always usually runs. It's really hard to implement when you leave it up to a person who might otherwise feel great, but still have a headache or still have a symptom that could be covered by taking a medication, and then telling them, oh, well, when you're symptom free, you can go back to work. So there's a lot of wiggle room in there and concerns that I have, not necessarily based on whether it's accurate or not, if implemented exactly as said, but more sort of the wiggle room that is available because people might misinterpret the fact that they're still symptomatic.
I think another aspect, if I could just add, is that it seems that it's like, well, why can't you make up your mind? You keep changing. And so that also impacts the faith that people have. But the analogy that I always use about COVID is it's like a hurricane, right? It changes its path. And also it's like a developing story. You can have a prediction from the forecasters, but the hurricane is going to do whatever it wants. And so we have to kind of be flexible and pivot. Having said that, though, it is exhausting. I mean, I can tell you as a clinician, it seems like the recommendations change all the time. I think the things that are still true, masking, and we have to, the cloth masks, unfortunately, are probably not going to be as effective as the other masks. And if you can get an N95 mask when you are around other people, that would be the most helpful. Physical distancing, as well as washing hands. But the majority of people that we're seeing are actually getting it from their family members. So let's keep it moving, because we're going to do a rapid fire. There are so many questions coming in. And if I skip and don't answer exactly, I'll come back, because I want to give everybody a chance to have at least one of their questions answered. Dr. Hancock, will we have a vaccine for those children under 5 soon?
Not likely until another couple of months. So the under 5 vaccine trial showed positive results in terms of little ones between the age of 6 months and under 2 to have a strong immune response with a very small dose of the vaccine. So they used 5 micrograms, 10, 20, and 30. And they were able to determine that with the smallest dose, that little ones between the ages of 6 months and 23 months were able to develop a very good immune response. Little ones between the ages of 2 and 4 years and 11 months, not so much. And so the FDA sent them back to do additional studies. Pfizer had the choice of either altering doses to see which dose triggered a stronger immune response, or adding an additional booster to see if, like for instance, a third shot would trigger the immune response. Pfizer made a decision to add a third shot to the series to see if that would provide sufficient immune response. They're in the process of figuring that out right now, which is why, even though it was anticipated that the 6-month to 4-year-old vaccine would be available by January, it likely will not happen until the early part of the spring, because they still have to answer that clinical question. My biggest concern is really systems being confused. We've already seen numerous stories being told about parents bringing their children in, and instead of getting the orange vial vaccine, they end up getting the purple vial vaccine, which is the adult version of it. And that's been concerning to parents, because clearly you don't want your little one to get a 30 microgram dose if they're not supposed to. And then you add into that, instead of it being a 2-dose series for all children, it's a 2-dose series for 6 months to 23 months. It's a 3-dose series for 2 to 4. And then we're back to a 2-dose series from 5 to 18. In medicine, we really base a lot of things on systems. And if the system glitches to where we have to have a completely different set of rules for one small subset of the population, it increases the likelihood of errors. And so the hope is that the FDA will compel Pfizer to also look at changes in dosing, so that everyone can still do a 2-dose series with potential boosters later on, as opposed to starting 2 to 4-year-olds out already with a 3-dose series.
I think that this COVID has really uncovered the weakness of our public health system. I mean, one group that I feel very badly for are actually pharmacists, because they're the ones that are having to fill prescriptions. They have to also administer the vaccines, not just the COVID vaccine, but also the other vaccines. I know that in some parts of the country, the National Guard has been deployed to do both testing and vaccinations. And I think, when we look at Washington, D.C., which up until last week, correct me if I'm wrong, was only behind New York City in terms of number of cases per capita, I wonder if that's not something that we can do, because I can tell you the number of errors that I'm seeing, which I understand on the pharmacist standpoint, or calling medications in and then they're not being refilled because they don't even have time to check the voice messages. I think that that's a reflection.
Yeah.
Not to mention, by the way, another consequence of all this is that, unfortunately, and it's mostly women, and it's mostly women of color, get the brunt of displaced anger in front line. I'm not kidding you.
Yeah,
I mean,
you're absolutely right.
Talk to the women at the grocery store checkout. I was there the other day, and the woman asked me, "Did you find everything okay?" I said, "Well, no, because of the problems with the supply chain." She said, "Thank you so much for saying that, because I've been getting yelled at." I'm like, "Getting yelled at? You have no control over that." So it's been very difficult. We're not even talking about mental health issues here, but there was another question. I'm going to pitch it to you, Dr. Clarke, about other variants coming down the pike. I mean, we've heard of Delta, we're hearing of Omicron. Is there no end in sight?
Unfortunately not. So one quick review about how our bodies produce variants. Every time a virus enters our body, its whole goal is to make more of itself. And it takes over our cells' machinery to do that. As the viruses are produced, there are changes that can just randomly occur in the manufacturing process. That's what produces a variation in the original virus, also known as a variant. So every time we've seen these infections, which are now in probably the billions across the world, each and every one is an opportunity for a variant to arise. And so we don't know what the next variant might be after Omicron. There have been reports of something called Deltacron, which is Delta and Omicron blend, so to speak, that caused a small outbreak in Europe. There's also been a report from somewhere in France about another variant. But I say, don't get bent out of shape by these variants reports, because we have a system of surveillance and monitoring to see, are these changes going to give it an advantage, meaning either an advantage in evading your antibodies that have been produced by prior infection or by vaccination, or is it going to make you sicker? And so thus far, outside of Omicron, we have not seen another variant yet, but that doesn't mean that one can't happen. And the quicker that we all get vaccinated and boosted, the more we wear our masks, the more we social distance, the more we avoid indoor dining and indoor venues where we're mixing with people, that's how we keep the spread of variants down.
Okay, I'm going to answer a question and then I'll come to you, Dr. Hancock. There was a question about, can we mix and match vaccines? And the answer is absolutely yes. And then Dr. Hancock, there was a question about long COVID syndrome among children. We definitely know that it occurs among adults. And what does it look like in children when it happens? And is it as common as in adults?
Excellent question. So what we know for both adults and the pediatric population is that for adults, around 10% of grown-ups develop long COVID. There are about 8% of children who develop long COVID. And it's interesting that long COVID symptoms are really based on age and gender. From a gender standpoint, what we see among women and children are more mental health manifestations, feelings of anxiety, feelings of depression, systemic issues like chronic symptoms similar to chronic fatigue syndrome, where no matter whether you sat on the sofa all day or tried to get up, you just feel completely exhausted. We see a lot of that manifesting for both women and for children. For men, we're seeing more organ-based long COVID issues, lung dysfunction. So they're not able to have the same lung capacity. They can go up the stairs, run up and down stairs before, they're fine. Now they feel more winded. We see more kidney involvement for men when it comes to long COVID. For both groups, we see that COVID can impair cardiac function. It's one of the reasons for children who had COVID, especially if they had the something called multi-system inflammatory syndrome, where a couple of weeks after having COVID, a little one can develop new fever. They can develop rashes, discoloration of their lips. Their lips look really red. Their eyes look like they have pink eye, but there's no crust and goopiness. They can have tummy upset, can complain of shortness of breath, because multi-system inflammatory syndrome, as it sounds, can affect every single organ in the body. And this is after a child has already been dealing with COVID-19 symptoms. If a child has that, they actually need to see a cardiologist to make sure that their coronary blood vessels, the blood vessels that supply blood to the heart, have not been impacted. So children are not only dealing with multi-system inflammatory syndrome, and it's a small percentage, around 2% of children who've had COVID develop that, but children are also dealing with long COVID symptoms. And so if your child had COVID, you want to make sure, again, to Dr. Gigi's point, we're not really delving into mental health, although that should be, I would recommend and the Rodham Institute does an amazing job, and I'm sure that's on their radar, but that's certainly, particularly for the pediatric population, is a conversation that we have not had enough of. So if your child had COVID, you definitely want to check in with them from a mental health standpoint to assess whether or not they're developing depression, anxiety, or any of those things. Even if they've not had COVID, a colleague of mine called me to find out what to do. His granddaughter wouldn't go to bed until her mother went out and got a COVID test. She had a little tickle in the back of her throat. She's 15. She couldn't rest until she took a rapid home test. And so now you're dealing with COVID anxiety. We've done such a phenomenal job of getting our young people aware of COVID that now some of them have significant anxiety as a result of not ever having COVID, but having the risk of COVID simply because they're more aware of the symptoms. And so we have to think about all of those things as we navigate our children through it.
So blackdoctor.org and the Rodham Institute on MLK Day are going to be having the State of Black Health webinar. So it'll be about COVID, a COVID update. The second will be about heart health. The third will be about breast cancer. And the fourth will be about mental health. Fingers crossed, we're trying to get Taraji Henson. So I'll be very excited about that. I actually sit on the Henson Foundation's Tribal Advisory Board. So you don't have to register. You just go on to blackdoctor.org Facebook or their YouTube channel, and that there'll be messaging on our website on that as we finalize the program. Dr. Clarke, I'd like to talk a little bit about medications and what's out there, because we're running out of medications. I mean, you know, you send people to get, I've sent people to get monoclonal antibodies, and the emergency department may have run out. There may be 16-hour waits, but we're also hearing that not all monoclonal antibodies are as effective for Omicron versus the Delta. Can you speak to that, please?
Absolutely. So I mentioned with variants that are able to evade the antibodies that have been produced, that's specifically what's happened with Omicron and monoclonal antibodies, which, just in case, so everybody knows, monoclonal antibodies are produced in a lab and they're given via IV, and they are made to be able to neutralize the coronavirus that causes COVID. But based upon the variations that have happened with Omicron, all of them don't work except one, which is manufactured by GlaxoSmithKline called Vir. So that one monoclonal antibody product is still available. But the key for all of these is to make sure that you get tested early in the course of the disease, because the earlier you get any treatment, the better it is in terms of your recovery. And so the same is true for the pills that have been approved. Pfizer has a medication, Merck has a medication that have both been authorized for use. And the good thing is they're not IV, you take them orally. They're not yet widely available, but when they do become available, again, taking them within 5 days of exposure and symptoms is going to be really key to make sure that they work appropriately. So that's it for outpatient treatment. We still have inpatient treatment, which really hasn't changed that much. I mean, we're still using antivirals like remdesivir, which specifically works against the virus. We use a medication called dexamethasone, which is a steroid. Once you enter the inflammatory stage, so once the virus itself is not causing damage anymore, but it's your body's reaction to the virus, the inflammation that's causing the problem. Once your body enters that phase, we use a steroid called Decadron or dexamethasone to help decrease that. And as far as airway support, we can use BiPAP, which is a mask that helps to push oxygen into your body so that your lungs can can still work even though they're sick. So those are some of the most commonly used. And then because of the inflammation, we know that COVID attacks the nerves and the blood vessels. When it attacks the blood vessels, it leads to blood clots. So using anti-inflammatories are also, anticoagulants, things that help to keep your blood thin, are also a treatment for COVID.
So just a couple of things to add. One of the things that we do in the hospital is we actually have people lay on their bellies because you can get more oxygen to your lungs that way. And actually our recommendations are at GWs, if you have COVID, to take a full adult aspirin to prevent blood clots. That's if you're outpatient. And I'm finding that especially for people at risk that might not need the monoclonal antibodies, I actually am more liberal with steroid use because it's an effective medication as long as there is no reason not to use steroids. That's just my personal practice. I would really check with your own clinician to see if that's something. Right now, there are only 3 pharmacies in the District of Columbia that have the oral medication, and it's only offered for people that are 75 and older or 65 and younger who have some conditions such as they're on chemo or they have some immunocompromised for whatever reason, their lung disease, emphysema, if they have something like lupus or rheumatoid arthritis, so kidney disease. So, but if you can imagine 3 pharmacies, that's something that, you know, obviously access to these pharmacies and also access to clinicians that know about these medications.
Right.
And so when we're talking about disparities, right, where pharmacies are not in the neighborhoods that are, you know, the places where there are higher complications, or the clinicians that are serving these communities may not know about that, that further widens the gap, because actually studies have shown that communities of color, when they do have COVID, are not offered monoclonal antibodies at the same rate. I should also mention, just for everybody's knowledge, that one of the things that's happening in the emergency department is they're actually testing for a particular gene to see if the monoclonal antibodies will be of help or not. Because right now the Regeneron brand is actually not particularly effective. It's 30%. And GSK, which Dr. Clarke mentioned, is much more effective. But this is one thing that just shows you when there is the profit motive that is involved, there is a price that human beings pay. The previous administration was in bed with Regeneron, and they blocked really the GSK from being, available
Manufactured.
and manufactured. So it's very, very tough to get any kind of GSK in the District of Columbia, and I think throughout the United States. I want to come back to the question, Dr. Hancock, about sort of what do you feel about public schools and DCPS in particular opening up? What's sort of the balance there in terms of teacher safety, child safety, child well-being in terms of going back to school?
Absolutely. But I want to touch on treatment real quick because it will lead into that, especially with how limited treatments are for children that have COVID. For right now, in terms of the outpatient setting, little ones now have access to monoclonal antibodies. The FDA gave approval for little ones as little as newborns to be able to get it. But to Dr. Clarke's point, when GlaxoSmithKline was able to release their product, they've only had about 50,000 doses in the entire country. So imagine in terms of prioritization, if it's 65 and younger or 75 and older, children are going to be the lowest people on that totem pole in terms of having access. The 2 medications that Dr. Clarke mentioned are not indicated for the pediatric population. And so children over the age of 12 will not have access to this. With the Merck drug in particular, because it is designed to create mutations within COVID-19 in animal studies and in the patient insert that we are required to give patients if and when we prescribe it, it specifically says that in animal studies that the medication was associated with cancer development and with birth defects, something called teratogenicity, meaning when you take it and you are pregnant or become pregnant, that it can facilitate birth defects. During the study, people were actually compelled to use birth control, and it's recommended that if this medication is used to treat COVID, that you either avoid getting pregnant or use protection if you're engaging in sexual activity. And so clearly, with those kinds of warnings with this emergency use authorization medication, parents for children over the age of 12 really have to give strong consideration to what your treatment options are. I always say, as we all do collectively, that prevention is going to be your best bet in terms of getting our children vaccinated right now. A little over 50% of children 12 to 17 are fully vaccinated against COVID-19 across the country. Less than 25% of children 5 to 11 are vaccinated. Have received at least one vaccine, right? And so when we think about those numbers as we're bringing our children back into school, as we ride the crescendo of this latest wave, it means that we have to take into consideration, how safely can we bring our children back to school? What I would say as a mother and as a pediatrician that just returning them to school with no measures in place, no testing, no sanitation plan, no social distancing plan, it's playing Russian roulette with our children's lives. We put them at risk. And not only that, we also put their educational experience at risk. Right now, I believe in the state of Michigan, they're trying to pass legislation because of their short-staffed space. They're allowing like cafeteria workers, no, not to cafeteria lady, but they're going to allow cafeteria ladies. Anyone who works at the school who has been certified to be around children, they are going to give them access to teach. I don't want my daughter taught by the cafeteria person. No, again, no, not, but I want someone who's trained to teach my child, to be the one standing before her in the classroom. If we have no mitigation strategies in place, that's going to be the story across the country. Either folks who are not trained to teach are going to teach, or schools, classrooms, and total schools are going to get shut down because of COVID. We have to pay attention to the numbers. We have to pay attention to some form of metric to decide when we will bring them back. Here in Prince George's County, where I live, the public school system shut down in terms of in-person classroom back before Christmas. Dr. Monica Goldson, one of Dr. Clarke and my sorors, our sorority sister, she made a decision before Christmas. We won't come back until January 18th based on the projected peak of the pandemic. My daughter's school, her principal did the same exact thing. We have to look at the numbers. We have to use metrics to decide, one, when they're going to go back, and then we have to use public health principles, public health practices to bring them back safely.
And I would encourage parents to find out at their school exactly what the COVID mitigation practices are. Ventilation was mentioned earlier. There were funds that were allocated to schools to be able to upgrade their ventilation systems so that they are in compliance with the recommendations. And ensuring that, you know, it's wintertime. You can't necessarily open windows, but if you could, making sure that the windows are cracked. So ventilation is really important. And seeing, do they have, you know, the staggered, you know, letting kids out of class so that not everybody's crowded in the hallway and the cafeteria at the same time. There are definitely principles of safe operation within schools. And again, because those vaccination rates are low, encouraging parents to get their children vaccinated, because that will also significantly slow the spread of the coronavirus.
And another concern is the change in the CDC's guidelines, right? So if you look at the CDC's website, it still clearly states that children should remain quarantined for 10 days, but there are school districts across the country that are now defining a child or staff member's ability to return based on that 6th day. And it isn't that symptoms are resolved. In the wording in the CDC, it's symptoms are resolving, right? And we know that there are going to be some students who are going to be sent back to school, still coughing, still sneezing with their masks on, that are going to put everyone else at risk. And so going back to those CDC guidelines, we have to be very, very careful in how we apply it in terms of messaging. We know children can't keep their masks on the entire time that they're at school. They have to take them off to eat, and children will be children. Yeah. So we have to be mindful of how schools will use these policies to put our children back in school and put them at risk.
And let's not forget, as we close out, that any issue that we're talking about, which is not being attended to positively, has a greater negative impact on under-resourced, underserved communities. So people say, well, just switch to remote learning. Well, we know that there's a huge digital divide, and also not all kids do well in sort of a remote. Some do better, but not everybody. So, ladies, I can't believe that our time is up, and I just want to tell you, I think that this is the most positive feedback that we've ever gotten. You should see all the comments and the questions. We should probably have a part 2. You guys are awesome. And if anybody who is listening wants to hear more from these 2 wonderful physicians and clinicians and friends, as you can see, advocates that are part of the Black Coalition Against COVID, please tune in on MLK Day, which is this Monday, to blackdoctor.org and the Rodham Institute's State of Black Health. So I'd like to really thank both of you, Dr. Yolandra Hancock, Dr. Melissa Clarke. This was fabulous. And And the accolades are just going up. I should probably read some. I mean, we've got, I mean, my God, at least 15. Thank you so much. Thank you from Neighbors Rising. Excellent session. Great to see you, Dr. Clarke. That's from, I don't know if it's a Dr. Rosalind Carr-Stevens.
Okay.
Thank you so much. Just wonderful, wonderful accolades. So thank you for educating all of us. And thanks, everybody. Please stay safe and please get vaccinated. Please.
Yes,
And
please
social,
do.
physical distancing and wearing your masks, and just as importantly, I should say, keep your sanity. It's been a long, long road, and let's pray that this is over soon.
All right.
Okay.
Thank you
Thank
for
you.
having us. Bye-bye.
Bye-bye. Bye-bye.